Sure.
Thank you. Can you see the slides? Sumona ma'am, are you able
Yes,
to
we
see
can
the
see.
slides?
Yes,
We can see.
yes, we can
Yeah.
see it.
So thank you so much for having me here. Thank you, Cheryl and Shubda, for having invited me here. So now I've been given a very simple topic. It's going to be a really short presentation. It's going to be managing diet with newer drugs. But just to understand that, diet, you need to manage diet with drugs. I have also included a couple of older ones, and I have not included drugs in which you don't have to titrate with the diet, or you do not need specifications of diet like SGLT2s or pioglitazone and other drugs. So we begin with the basis. A key component of diabetes self-management education is counseling people with type 2 diabetes and also type 1 diabetes as they initiate treatment with new medication by informing them about treatment options, how medication works, how administration instructions have, and what to expect regarding efficacy and potential side effects of these medications. So just before my talk, there was a beautiful skit which was done by Udan, people with Udan. And you would saw there that, in very simple regional language, using regional folk art, they actually showed how to, change the site of injection to prevent lipose. So similarly, when a person with type 2 diabetes is undergoing OHA treatment, it's very important for them to understand what these OHAs do. And it is also very important for us as educators, especially dietitians, to sort of tell them what to look out for and not look out for when they are on a particular kind of OHA. So I'm going to go to the good old SUs, sulfonylureas, and again, I am not going to dwell a lot in detail about what they do. I'll just, in short, they act by increasing insulin release from beta cells, may induce hypoglycemia as a result of excess insulin production and release. So this is a point which probably dietitians and educators need to sort of think about or take into mind about that they can induce hypoglycemia, and hence meal planning around this is very, very important. This will typically occur if doses are too high or if the patient is fasting and is taking this OHA SU on fasting. Like insulin, sulfonylureas can also cause weight gain, mainly as a result of their effect to increase insulin level and thus utilization of glucose and metabolic fuel. And then other side effects are GI upset, headache, and hypersensitive reaction. Sulfonylureas bind to close ATPase-sensitive potassium channels on the cell membrane of pancreatic beta cell, which depolarizes the cell by preventing potassium from existing. This depolarization actually opens the calcium channel, voltage-gated channel, calcium channels. This rise in intracellular calcium leads to infusion of insulin granules with cell membrane, and therefore there is release of mature insulin. Now, what is the lifestyle modification with SU? Every meal in SU should be accompanied by carbohydrate. Now, why am I saying that? This was not something we said a couple of years back, but now we say because ketogenic diet or low carbohydrate diets have become extremely popular, and most of the people, when they start following these diets, they actually do not go and consult anybody. They start doing this diet on their own, and therefore, whenever you see a patient with type 2 diabetes and SU being given to them, it is important to tell them that these medications need to be accompanied by carbohydrate in their diet. So if your breakfast has SU, you obviously just can't eat an omelette. You need to eat a chapati with it, or maybe eat some other carbohydrate with it. And that's very, very important. Now, what happens is SUs are generally given twice a day. Yeah, the afternoon meal where SU is not given can have lower calories and lower carbohydrate, because in the last slide we saw that weight gain is a major problem with SU. And if you want to, if somebody is on SU and still wants to maintain weight, then in the meals with SU, you have no choice but to give them carbohydrates. But there will be a meal where, you could go lower on carbohydrates. I'm not saying go carbohydrate free. I'm just saying go lower on carbohydrates, and you can manage, diets like this. Then biguanides, that's metformin, again, a old drug and very, very popularly used. I think most of us know this. So metformin is a complex drug with multiple site of action and multiple molecular mechanism. Physiologically, metformin acts directly or indirectly on the liver to lower glucose production and acts on the gut to increase glucose utilization, increasing glucagon-like peptide 1 and alter the microbiome. So metformin has many, many actions, but very important, I'm not going to go into detail, is as biguanides do not stimulate insulin secretion, hypoglycemia usually does not occur when they are used alone, and therefore sometimes they are called as anti-hyperglycemic agents rather than hypoglycemic agents. So this is something that you have to know, that biguanides usually do not cause hypoglycemia, and therefore your diet can have varying levels of carbohydrate when your patient is on metformin. So what does the research say? Research says that while no particular diet is absolutely necessary to follow, it is best to eat high protein, lower carbohydrate, and lower fat diet while taking metformin to make sure that medication is effective as possible to help you manage your blood glucose and also help you to, if not just manage, lose weight. Aim for fruit, vegetables, lean protein, low fat dairy, unprocessed whole food as much as possible. Metformin is usually associated with vitamin B12 deficiency, so look at food as well as supplements containing vitamin B12. What its side effects are: metformin can cause nausea, lot of acidity in lot of people. Also, in people who are intolerant to it, may cause diarrhea, vomiting, decrease in appetite, bloating, and gas. So these are things that you need to take care, and hence it's important to give this medicine after food. That's one thing, and also try to include whole foods rather than processed foods while taking metformin. Then again, AGIs, older drugs, but again, important one. Alpha carbose is one of the alpha glucosidase inhibitor, has shown slows down the breakdown of disaccharides and polysaccharides and other complex carbohydrate molecules into monosaccharides. So the enzyme that breaks complex carbohydrate, whether it's disaccharide or it's polysaccharide into monosaccharide, is called as the glucosidase enzyme. And these drugs, that is acarbose and other drugs like them, voglibose and other of them, actually slows down the breakdown of polysaccharide or disaccharide into glucose. So enzymatic generation and subsequent absorption because of this is delayed, and post-food blood glucose values, which are characteristically high in patients with type 2 diabetes, are actually reduced. So AGI compete with oligosaccharides for binding sites at the alpha-glucosidase enzyme. This slows down the rate of digestion of carbohydrates and alternately postprandial rise in blood glucose level. Insulin sparing mechanism helps in reducing degree of hyperinsulinemia that is often seen with diabetes. Hypoglycemia, again, it is rare with AGI, but when it happens, it has to be sucrose should not be given because it's a disaccharide. Alpha-acidic glucosidic bond has to be broken for the absorption. So try to give a monosaccharide like glucose if there is a rare hypo with AGI. Now we are going to go to newer drugs, which are two, which I'm going to discuss. One is SGLT2 inhibitors and another is semaglutide. So SGLT2 inhibitors are a relatively new class of OHAs used for person with type 2 diabetes. The drug's main mechanism of action is via reduction of renal tubular glucose resorption. The drug's mechanism does not involve stimulating insulin release. SGLT2 have shown to promote weight loss, reduce blood pressure, making them an attractive choice of drug for patients who have concomitant hypertension and obesity. So we know that generally in type 2 diabetes, all three go together. There is usually, in most of the cases, there is type 2 diabetes, there is obesity and also hypertension. And I think this is one drug which actually works all through. So I am just not going to take these slides because this is pharmacology. So I don't think we need to go into it. I'm going to go into what are the similarities of SGLT2 with ketogenic diet. So SGLT2 inhibitors are similar to some dietary changes that are inherently done with ketogenic diet, due to their mode of action, they decrease glucose oxidation in favor of fat oxidation and promote free fatty acid utilization. Use of SGLT2 inhibitors with adherence to ketogenic diet and to intermittent fasting can lead to diabetes ketoacidosis with profound acidemia. So what happens is SGLT2 by their mode of action actually throw out glucose from the body, and hence like ketogenic diet also throw out water and sodium from the body. And what you will find that if you do ketogenic diet or a very low carbohydrate diet with SGLT2, you are doubling the effect of SGLT2 with ketogenic diet. So SGLT2 works very, very similar to ketogenic diet. And if you do both together, it is like doubling it up. And that will actually lead to person to cause DKA with profound acidemia. So in India, currently approved SGLT2s are Cana, DAPA, and empagliflozin. So this is a very, very interesting slide where therapeutic carbohydrate restriction, which is very, very popular nowadays with less than 40 to 50 grams of carbohydrate per day, and SGLT2 inhibitors were compared, and you will find that almost most actions are similar. So glucose uptake is decreased here. Here, glucose excretion is increased. So what happens in general, either you take in more glucose or you throw out more glucose, the homeostasis is maintained. It will lead to HbA1c reduction. In fact, it will reduce it 2 to 3 times, whereas in SGLT2 inhibitors, it will reduce it to 1 to 2 times. So you can see low carbohydrate diet is more potent in reducing HbA1c as compared to SGLT2 inhibitor. Insulin, again, levels drop in both carbohydrate restriction and in SGLT2 inhibitors, but with carbohydrate restriction, insulin levels drop. Further, weight loss is also much more profound with low carbohydrate diets and as compared to SGLT2. Blood pressure drop is also there. Low carbohydrate diets tend to increase HDL in most of the cases, but here it can decrease to increase, but not as much. LDL increases. Triglycerides drop, but drop more with a low carbohydrate diet. And ketones are higher, of course, because this is a ketogenic diet. You want ketones to be higher, but even with SGLT2 tends to have ketones. So when these two go together, you can just imagine the amount of ketones which will be generated, and that is actually why low carbohydrate diets should not be followed with SGLT2 inhibitors. The side effects here with low carbohydrate or therapeutic carbohydrate restriction may cause keto flu, constipation, hypotension, and dizziness. Whereas here, the problem is because there's so much of glucose which is leaked through the urine, there is a high risk of genitourinary infection, hypotension, and increased risk of amputation. Okay, now we go to the newer one, which is semaglutide, which has come in Indian markets very recently. So, glucagon-like peptide-1 receptor agonists are effective treatment options for achieving glycemic control and body weight reduction when combined with diet and exercise, with an added advantage of having a lower risk of hypoglycemia and potential cardiovascular benefits. For this reason, GLP-1 receptor agonists are currently recommended as second-line therapy option in people with type 2 diabetes after metformin and intensive lifestyle intervention. Also, a lot of people recommend SGLT2 before this. So what is the advantage of this GLP-1 agonist? It promoter of insulin secretion, suppresses release of glucagon in glucose-dependent manner. GLP-1 receptor agonists also have beneficial effects on body weight, which are mediated in part by increased satiety and lowered gastric emptying. Due to their glucose-dependent mechanism of action, GLP-1 receptor agonists convey a very, very low risk of hypoglycemia. They have demonstrated superior cardiovascular outcome as compared to placebo in patients with high-risk CV history or history of cardiovascular disease. Now, what are lifestyle modification education with semaglutide? So, you have to remember drug to drug interaction in this case is thyroid medication, glipizide, and bisphosphonates. Food issue. There are severe GI side effects like nausea, vomiting, abdominal pain, reduced appetite, and constipation. And most of the time, dropouts with this therapy is because of these GI side effects. So most of the people who begin with this kind of medication, they will, probably go back to doctor and say that I just cannot handle the GI side effects and hence drop it out. Most during dose escalation period, mental preparation and dietary modification is required for same. So your psychotherapy also plays a very, very important role, that you have to prepare this patient before you start with this medication. Importance of monitoring and understanding blood glucose. Patient and their families should be educated on preventing, recognizing, and managing episodes of hypoglycemia. Although they are very, very rare, they should be taught. So hypoglycemia management should be taught to everybody. Semaglutide can be given in patients with moderate renal impairment. Specific dietary guidelines like protein, fluid, electrolyte restrictions, I'm sorry, there is a typo here, have to be maintained. So it is not like, if you're given, they are given in patients with renal impairment, and hence if somebody has a lower EGFR, you need to maintain guidelines of protein, fluid, and electrolytes as per whatever the blood reports show. So this is just a, sorry. Okay, so oral semaglutide is a prescription medicine for adult with type 2 diabetes. Oral semaglutide is a GLP-1 receptor agonist. Now, how should patients take it? Upon awakening, take it on empty stomach with a sip of plain water, no more than 4 fluid ounces or 120 ml. Swallow the tablet whole. Do not split or crush or chew the tablet. Wait for 30 minutes before the first food or beverage or other oral medication of the day is taken. Any missed dose should be skipped for that day, and the next dose should be taken on the following day. The most common adverse effect reported in greater than 5% of patients treated with oral semaglutide are GI disorders like nausea, vomiting, and diarrhea. Following strategies may help patient to get relieved. So eat smaller meal for first few weeks following initiation of treatment, as you may feel fuller more quickly than usual. Eat slowly. Stop when you start experiencing feeling of fullness. Food. Well, the example, this is an international paper, so example are given as cracker, toast, and rice, but you can choose any kind of bland foods which are there. So maybe a khichdi, maybe a plain paratha with dahi or something like that. So choose something which is good on protein, low in fat, and you can give these kind of foods. So again, these are actually other medications. So here they have said that patients may, in case of thyroxine, along with semaglutide, patients may be advised consider taking concomitant levothyroxine in the evening, at least 3 hours after their last meal on the day, which would still ensure optimal and consistent absorption of levothyroxine if thyroid, the person also has thyroid. So it can be taken after 3 hours after dinner, which will help, which will prevent drug to drug interaction, especially when it's very common for people to have thyroid and also have type 2 diabetes. So with glipizide, because there is a risk of hypoglycemia when oral semaglutide is used in combination with sulfonylurea, the dose of glipizide or any SU may be lowered, but this is something that the doctor is going to do. So I'm going to end with this slide. This is a very, very nice slide. And I think if you want, take the picture. There is a reference here. Please read this paper. It's a very, very nice paper. So this is traffic light system about how to eat, a stoplight approach to medical management with therapeutic carbohydrate reduction. So when reducing medication, patients must check blood glucose frequently and have immediate communication with their clinician. So whenever they think that their blood sugars are dropping, please tell them not to drop it themselves, medications themselves, but to visit their clinician and get them dropped. So with green light is for baguanides, GLP-1 agonist, and DPP-4 inhibitors. Here, even if you reduce carbohydrate in the diet, there is no problem. It's a green light. They can eat a low carb diet and still be on these drugs. If they have to reduce the levels of basal, that is a long acting insulin, to 50% and THDs if they are going to go on a low carbohydrate diet with these drugs. But they have to stop a low carb diet if they have to go be on sulfonylurea, metaglenides, SGLT2 inhibitors. If they are on bolus mealtime insulin, they will need a correction and lowering the dose of bolus mealtime insulin, combination insulin like 70/30 and AGI. Thank you so much for a patient hearing. I'll be happy to answer any questions